I've been doing these spring forums now for either in person or virtually for 6 years, and this is maybe the first time that all of our speakers have been speaking about things pertinent to our lives, but not necessarily specifically to Parkinson's disease. So I hope that you found our speakers this morning informative. I know you're going to find Mike Hoffman from Mariner Health Consulting informative as well. As we talked about, here's how expensive it all could be and where to move your money, but it's also important to understand how to navigate insurance and how that plays in and planning financially. So without further ado, I'm going to bring up Mike Hoffman from Mariner Health Consulting, and he'll help us understand insurance.
All right, so again, my name is Mike Hoffman, and I think this has been a fantastic forum. So congratulations and thanks for being here. I think this is how change happens. This has been a great event. And I'll start with a few familiar faces, hopefully. Hopefully you guys like Lucy and Charlie as much as I do. We have Lucy here. You guys can see this. Lucy here in her normal kind of doctor mode. And we, of course, have Charlie Brown, who's always questioning everything, but pretty gullible. You know, before we begin, I'd like to ask you something. What are your credentials, says Charlie Brown. Lucy says, I know everything. And Charlie says, well, hey, those are good credentials. Might as well listen. Right? And I bring that up because I don't know everything. I can tell you that the speakers before me, there were some fantastic bits of information that I got. So hopefully you all have learned something today. And what I would encourage you is these are just resources for you all. Okay? I am, the other speakers are. Use the advocates and the resources that are out there for you. Okay? And I'll talk about that as I kind of go through my presentation. All right, so what are my credentials? Mike Hoffman, I'm an independent certified agent. My agency is Mariner Health. Being independent, in my opinion, in the Medicare space is a valuable thing because you want to make sure, so when you hear independent and folks are working with Medicare, it means they aren't tied to any individual carrier or any type of product, okay? So I'm independent. I work with all the different carriers. I work with supplement plans, Part D plans, Part C plans, really all of them. I'm an econ major from Ohio State, behavioral science, and econometrics were my concentrations, 30 years of experience in finance and insurance, and I have a certificate in patient advocacy through University of Miami in Florida, which I do some of their Medicare presentations for their new students too, okay? Do that over the phone. So how I help folks, if you've stopped by my table, we've talked about it, but I provide, essentially I work with folks to help understand what their needs are. So I'll sit down and do a consultation. You know, do they have network needs? Do they travel? What are they comfortable with? We'll talk about how you pay for insurance, right? How the costs kind of come to you and help make educated choices based on those discussions, okay? So I present and review the options with them. We'll look at multiple providers and carriers. I do a lot of Medicare, but I'll also work with long-term care, whatever needs that person has. It's kind of the whole picture. So essentially senior needs insurance is what I work in. And I'm ultimately an advocate for consumers, right? I want to make sure that you guys get what you need and get the help that you need. And that's true when a client calls me and they have a bill they don't understand. I mean, who's had that in the room, right? It's part of my job to help you know how to navigate that system. It's okay to ask questions. And I would encourage you, when you get a bill you don't understand, ask a question. Call the agent that worked with you on it. Call somebody that you know that's an advocate for you, okay? It's okay to call the insurance companies and ask them questions about a bill that you have. It's okay to appeal to. So I thought I'd start with the definition of insurance because we don't talk about it, like what insurance actually is very often. We're kind of used to it. But at the end of the day, the definition is a coverage by contract whereby one party undertakes to indemnify or guarantee another against loss or peril, contingency of peril. It's a long-winded definition. Essentially, we're protecting from that peril, right? We're protecting from something that's going to create danger. This person, this young lady, looks fantastic, looks very happy on her skates. Is she potentially in peril? Right. So health insurance is probably good for her. She may fall, right? So we don't know what's going to happen. We don't know the future. What about these folks? They look happy. But I can tell you right now, I have a 15-year-old who just started driving last week, and she's terrible, right? She has a lot to learn. And the first thing I tell her when I looked at this, these people are very happy. They're enjoying their joyride, but they're not looking at the road, right? There's a big peril there. So insurance is important, and we'll talk about Medicare. We'll talk about long-term care. We'll spend a few minutes to talk about each one of those pieces. But it's important because we don't know what's going to happen. We just want to make sure we have coverage, right? And coverage looks very different. We'll talk about Medicare because at the end of the day, it's not that complicated, but it's complicated enough that you need to talk through it, okay? And you need to understand what you have. Another bad day not to have health insurance. I think, and this is kind of a random one, but another bad day kind of caught me. So obviously whoever drew this was recognizing that bad days happen a lot, right? And that we need to have health insurance to protect from that. So of course this person's speeding, again with a young driver, also recognizing that you got to drive in a speed limit, but going to a bridge that's not finished. All right, so with Medicare, at the end of the day, I want us to be confident. I want us to know what we have and be comfortable with the decisions that we've made and where we're going. I can't tell you how many people I talk with who come to me because they don't know what they have. They might have been on Medicare for 10, 12 years, and they don't know what exactly they have and how it's structured and how it pays, okay? And often they'll know what their neighbor has. They'll hear something nice that their neighbor maybe is benefiting from, and they'll maybe jump into that without thinking about what they currently have and if it works for them, okay? So the more we know about insurance and about Medicare, the better. So let's get some confidence today. We'll talk about the basics. We'll talk about basic terminology. We'll talk about the enrollment periods because that's a big deal in Medicare. We'll talk about plan types and how to look at recommendations. And there's also cost assistance, which I thought the presentation before was fantastic. I've not heard that before. But there were a lot of good points by the elder law, like Eva from elder law. That was a fantastic presentation. There's a lot of cost assistance that's out there, and I'll give you some of that as well. But just, again, be resourceful, use your resources out there. And again, the more we know, the easier making our plan choices and knowing how our coverage works is going to be. So what is Medicare? You guys could probably tell me this. It's a federal health insurance program. CMS is terminology we see a lot, right? You'll see that in the papers. You'll see that every time you see an increase in the Part B premium or anything else. That's the Centers for Medicare and Medicaid Services. They run Medicare, so you're going to see those interchangeably used. And it's part of the Department of Health and Human Services. So there are a couple of slides in here that I want us to walk away. If you get anything from today, this is an important one, and hopefully you know a lot of this. But these are essentially the 4 ways that you pay inside health insurance. A premium, right? A premium is going to be typically something paid up front, paid monthly. It's usually a consistent payment, and at least for that period of time, that 12-month period. And we pay that up front. We get a benefit from that. That's one way to pay. Deductibles are another. Right? Deductibles are a limit that you generally pay up to get a benefit, right? So once you hit that deductible, then the benefits start kicking in or the lower rate kicks in. Copays, that's if you go to the doctor and you have a fixed payment that you pay. That's a copay. Coinsurance, which is an important one because that's what Medicare is based on. We'll talk about original Medicare on the next slide, but coinsurance means you're paying 1%. Okay, so when you think about original Medicare, that's 80-20. They pay 80% of the cost, you pay 20%. That's generally the way it's designed. So we have those 4 ways are the way that payments are made in Medicare. So original Medicare, when I say that term to folks, they don't really know what it is. They just know they have A or B or A and B. But original Medicare is A and B together. So when you're on A and B, that is original Medicare. And again, that goes to the 80-20, right? They're paying 80%, you're paying 20%. The challenge with that, and what we'll talk about on the coming slides, is there's no cap to that, right? So if you're in a hospital, you're going to pay 20%, and if you're in a hospital 2 or 3 times that year, there's no cap to that cost. Okay, so that's why it's important for us to think about that in a little more detail. What do these parts cover? Again, it's something that I'm a lot of folks don't realize or know. But Part A is hospital insurance. I think we all probably have heard that. There's not a premium for that typically for most folks, although you can buy into it if you don't qualify for it. It helps pay inpatient hospital stays, skilled nursing, hospice, home health care. So all things that we'll use at some point, okay? But that is Part A. And then Part B, which I like to say is where we generally see care, use care more often. That's your preventative medicine, that's your doctor's visits to a local doctor, your primary care or specialist. That's outpatient care, home health care is included in that as well. Durable medical equipment, which would be canes, walkers, any devices that you would have to have that would fall under Part B as well. And then preventative medicine, vaccines are typically going to fall under Part B as well. And of course, Part B is the section that we would pay a premium for. Okay, and that premium, the standard, I'd say the lowest level would be that $164.90. That is great. That tiers up based on income. Okay, so I'd say the lowest cost of what most folks will pay would be that $164.90. If you have higher incomes, it could be higher than that. So original Medicare eligibility, I think most of us know this, but just to review it, 65 or older, it's important to note not everybody is over 65 that's on Medicare, right? You can be on disability by Social Security's definition, be on Medicare, and then actually when you turn 65, there's a window that opens to go in, as you're turning 65. You could have end-stage renal disease or ALS as well and qualify for Medicare. Be a citizen of the U.S. or be here for 5 consecutive years. So with original Medicare, we all know it doesn't cover everything. All right, Medicare covers a lot, but it does not cover everything. So there are ways, and again, we have that same issue with the co-insurance. There's no cap. So we have to have other considerations. And I'd say ultimately, this would be the key slide that I would want you to walk away remembering. There are really 3 ways to do Medicare, all right? And think about what you have today. So original Medicare, A and B, you get your red, white, and blue card. It's got your number on it. It's got the dates you came into A and B. And then you would potentially add a Part D plan. And that's what you're going to use to get your prescription drug benefit. Okay, and that's an important piece because if you delay that, that's where there's a penalty that can be associated with it. I run into people all the time that get A and B and do not get D because they're not taking a medication. I usually encourage looking at it because you want to make sure that eventually you may need it. So Medicare does not cover prescription drugs, so you want to make sure you have that coverage so you don't have to pay a higher rate later. So you have one. Option 2 would be similar. You have your A and B and your D, and you add the supplement plan on top of it. Okay? So you'll hear a G, an F plan, an N plan. You have all these different letters. That would be what Medicare supplements would be Medigap. Okay? That's intended to cover that 20%. That will cover your co-insurance part. So Medicare covers their 80%. The Medicare supplement or the gap would be the amount that you owe. So that's another way to do Medicare. And the third option would be a Medicare Advantage plan. And those are what we would consider Part C. Okay? Part C is privatizing Medicare. So Medicare contracts with a local carrier or carrier in your zip code. They build a network and they offer benefits to you through that plan. And then those plans will typically have, so when you see the commercials on TV, who's seen a commercial on TV? Hopefully everybody has because there's a lot of them. And I can't tell if those are good or not. But they will promote often dental benefits, hearing, vision. Those are extras that Part C plans will offer, okay? And they'll offer in a lot of different ways. So going through each one of these, Part D plans, you'll have specific, so they're not all the same, and the premiums can vary quite a bit. So it's really important to look at what you're taking and what your needs are and analyzing that to make sure that the plan you're in makes sense for you. Because I'd say of all the plan types, these are going to change the most year to year. Okay, formularies will change, premiums will change, the way the coverage is, the pharmacy coverage will change. So prescription drug benefits and Part D, I would make sure that you look at each year. But you'll have a specific list of drugs. Not all drugs are covered on every plan, right? So insulins, can be offered typically, at the lowest rate, but it might not be the insulin that's on that formulary. So those are items that you want to make sure you're looking at. They're sold by private companies, so your Anthems, United Healthcare's, all the carriers are going to be offering these, and they're going to have monthly premiums that will generally be you'll never see more than 3 per carrier, and they'll usually be tiered. You have a kind of a higher cost, low cost in the middle, okay, from a premium standpoint. And then you have tiered copays. And some will have a deductible as well, which is important to look at because it may look like that deductible applies to you, but if your medications don't fall in those tiers, it won't. So again, an important thing to kind of look at. There are great tools. Medicare.gov is a good tool. I'm happy to look at it with anybody as well. But you're going to get your drug benefit through a standalone, or you're going to get it through a Part C plan. We'll talk about Part C plans. Then we had the second option where we had the original and we had D, and we added the supplement plan. So 14 million Americans are on Medicare supplement plans. That helps cover the costs and services that are, it helps cover your cost in original Medicare. That's the gap part of it. So it helps you cover the out-of-pocket expenses. It does have, if you're doing it today, you're going to have a Part B deductible. So you're going to have that portion, but in the end, it's again geared to help pay that percent for you, depending on what type of plan you go into. So, and the types are kind of nice because they're standardized across the country. So I would say an F plan in this state is going to look it's going to be the same as an F plan in another state. So it's very portable. Now you may have a different rate if you move, and I run across those quite a bit, but you don't have to change plans, right? If you move from like maybe here to Indiana, or somebody moves from Michigan down here, you may have to change, and often you'll have to change your Part D, but you won't change your supplement. So they're very portable. Again, these are private companies. Premiums vary state to state, which is why when you move, you have to update the carrier that you've moved. And they can require underwriting. It's important to know when you first get Part B, you have a right to not go through underwriting to get guarantee issue. So that's an important piece to this puzzle, but that also doesn't exclude you from getting Medigap. So I run into folks all the time that are on a Part C plan, and they want to look at a Medigap. There's nothing wrong with doing that. And you'd be surprised. There's a lot of different, supplement plans out there. You can always apply and see if they'll take you and see what the rate is, and then you can accept it or reject it, okay? So don't just assume because you go through underwriting you won't get what you want. Okay? And they're often paired with, of course, original Medicare and a Part D plan, so you have full coverage, and you must be enrolled in Medicare A and B to be eligible. And then we have our Part C plans. So Part C plans, by design, are built to cover A and B benefits. So they're supposed to cover everything under A and B, at least at the same rate. And they cover prescription drugs as well. Many will. So we would call that an MAPD. And their premiums are going to generally vary quite a bit. Most that you'll see, shouldn't say most, but a good chunk that you see around town here will have 0 premiums, which isn't necessarily free. You're paying your Part B, and you may have a low premium because of that too, right? You continue to pay Part B, and you can join a Part C plan and have a low premium if you have a premium at all on top of the Part B. You'll have an annual a maximum out-of-pocket, and that's a fixed amount. That's not a deductible. That's an amount that as you make co-payments, that would be the cap that you'd have for that year. So it's a lot different than a deductible where you have to hit a certain limit before you get the benefit. People confuse that all the time. And they do have a network of doctors and hospitals, whereas the original Medicare and the supplement plan does not. Okay, so those anybody who accepts Medicare and original Medicare or the supplement, you would go get care and they would accept it. You have a network of doctors if you're in a Part C plan or an Advantage plan. Private companies, again, these are all typically guaranteed issue, which is an important piece. You don't ever go through underwriting. You can join a Medicare Advantage plan without going through answering any health questions, and they're not paired with supplement plans. Although I've seen that before, it's kind of crazy. But you're not supposed to pair these with a supplement plan, so you wouldn't have a supplement and a Part C. Okay, and you must be enrolled in both Medicare A and B. And that's important because the Part B, you have to be making that payment, right? So the enrollment periods, which you guys hear a lot about because the commercials tend to time with those, right? You have the end of the year, which is the October 15th through December 7th. That's the annual election period. That's when everybody who's on Medicare can really make any choice. So if you're in a supplement plan, you can go to a Part C. If you're in a Part C plan or an MAPD, and a Med Advantage plan, you can go to a different Med Advantage plan. That's the time of year that everybody can make a change for the next year, okay? Which means plans, particularly the Part D and Part C plans, will change, and you'll start knowing what those changes are as you get into October, okay? So that's an important time of the year. That's something everybody tends to have some involvement in. Outside of that, there are really only a couple ways to get into Medicare. One would be your initial enrollment, which is 7 months, the month you turn 65, the 3 months before, the 3 months after. Okay, that's our IEP or our initial enrollment period. And again, these are important dates to know because if you're turning 65 or you know someone turning 65, there are certain rights that they get when they first come in that are just important for them to know. Then you have special enrollment periods. There's actually a lot of those. And I'll show us a few on the next page, but that could be moving from one county to another county. That could be moving from Toledo to Cincinnati, right? If you exit the area that you bought the plan, oftentimes that qualifies you to look at your plan again, okay? Because there may be different benefits. The prescription benefit may be different. There may be different pharmacies in that drug plan. So that opens up a window for you to look. If you're on Medicaid, or if you know people who are on Medicaid, they'll have special election periods throughout the year. So they can make changes throughout the year. And part of that's because their needs are different, and they also may change status more frequently. Then you have open enrollment, which is a period that you don't see marketed, but it's a period where people that are in Med Advantage plans can make changes. So we just ended that yesterday. So yesterday was a busy day. But that's the first part of the year, the first quarter of the year. People who are in a Med Advantage plan can change to another Med Advantage plan, or they can exit and go back to original Medicare. But very important because there's really no way to get into Medicare outside of these options. Special election periods, again, a few more reasons. So moved out of the area, Medicare and Medicaid, we would call that a dual special needs. Or if you currently retired, a lot of folks today continued working, right? They turned 65, they might have gotten A, but they may be interested in either continuing to work, but preparing to leave work. And you can leave your employer plan, and that opens up a window to join Medicare. So you sign up for Part B, exit your employer coverage, you're eligible under a special election, okay? That's a pretty common one right now, the last few years. And then, COBRA, when folks go on to COBRA, it's important to know that that's not considered credible coverage. So credible coverage is an important piece to it, because if you don't have credible coverage and you delay, you can have fines that kind of add up for continuing to delay. So it's an important piece too. So again, these are not things you're going to use very often, which is why when you have questions, just make sure you're using a resource. So for cost assistance, I think you've gotten some good presentations and some good information today about this. Again, I thought the presentation before me was fantastic in that sense. But there are a lot of programs out there, and I would encourage, there are a lot of programs, I see it every day. People just don't know what the options are, who's out there to help. But you have Extra Help, which is a service that can help with prescription benefits. You have the Medicare Savings Program that's designed to help you with Part B payments. You have Medicaid, which has several different tiers to it, depending on your income and your assets. And you have PACE, and you have a lot of local groups that are willing to help, including the groups you're with today. So just know that there are programs that are out there. If you have questions, don't assume that you aren't eligible for something or that there's nothing that can be done. Just talk to somebody about it, okay? So when looking at advice, and it's certainly as you get closer to the end of the year and you start working through the annual enrollment period, licensed insurance agents can be very helpful. And I'm a little biased, but to me, somebody who's local or regional, who you know or have access to or you trust, obviously are very important. But they have to be certified to offer, for everybody who's offering Part C and Part D plans, they have to be certified through Medicare, and they also have to certify with every group that they carry. So there's actually quite a bit of tests and quite a bit of work that goes into that. But they're trained to assist you with choosing plans. They certify every year. So these are things to ask your agent about or talk to your agent about. Lots of things impact which path you choose, whether you do a supplement of Part D or whether you do a Part C plan. That may be your budget, might be your doctors, might be whether you plan to be here or maybe relocate, whether you travel, where your kids are, that type of thing. Lots of things can go into that. That's why it's important just to talk through it with somebody. So let's talk about some special considerations and some special issues that come up for folks in the room and how it's covered. So coverage, hospital care, medication, these are all things that in the room we're dealing with, right? Hospital care, medication, home health care, DME or durable medical equipment, outpatient, all the specialists that folks might see, mental health services, training. There's some fantastic resources that are in the other room that deal with specifics for this group. Rehabilitation, skilled nursing, which tends to impact us all as well. Things that Medicare doesn't cover, and I guess the way I would delineate this is independent living, long-term care, nursing homes, but the custodial part, right? That's the part that tends to catch everybody up. And assisted living therapy that's not approved, right? So it's not medically necessary. Will tend to be out of pocket. So Medicare covers a lot, but it doesn't cover everything. It does have limits. And typically that limit would be if you require custodial care and you don't have skilled care associated with that. So how are these covered under Medicare? Hospital care, Part A. I should have quizzed you guys. Medication, Part D or your Part C plan, however you're getting your prescription benefit. Home health care, therapy, Part A if it's rehabilitation. It can be Part B as well. DME is going to fall under Part B. Outpatient, your specialist visits, your primary care, Part B. Mental health is going to be under Part B. Training and exercise facilities. So a lot of plans will offer, actually, a lot of folks don't realize this, but if you're in a supplement plan, you'll generally have, a lot of folks will have the option to have silver sneakers, or they'll have some type of benefit that will give them exercise, like not just a gym membership, but also access to tools or resources in their community. So it's important to look at that. So the plan that you have may offer above and beyond what Medicare offers. So training and exercise, some of those programs are built into that. So again, I encourage you to look at it. And then rehabilitation, skilled nursing. So an event happens and you need to get care, you need to recover, right? So that's covered under Part A. Medications, COMT inhibitors, MAO inhibitors, Part D or your Part C plan. Physical occupational therapy is going to fall under Part B. Testing, diagnostic testing, Part B. Any kind of therapy or stimulation tends to fall under that in a outpatient setting. It's going to be Part B, infusions. So coverage is limited though, right? We talked about that. Independent living, long-term care facilities, you're going to see a lot of the same ways that you pay for this. Private pay is that's generally going to be a factor of this. Even if you have a long-term care, there's typically a period of time you're going to have a private pay, and we'll talk about that. But independent living, long-term care, assisted living, and home health aids and therapy over and above maybe what's already been approved. Okay, so there are limits to what can be offered. Now, long-term care insurance, I thought we'd spend a few minutes talking about long-term care because that comes up a lot. And I think with long-term care, really any insurance, I think this is an interesting way to look at it. I'm afraid the policy won't kick in the next 30 seconds. So I can't tell you how often people come and look for long-term care insurance when they need it. And we all know that's not really how insurance works. So to me, long-term care is something you think about as early as there's a period of time that you want to really look at it to maximize the premium. But I find a lot of folks a lot of just basic education about what it is and what it isn't is helpful. And again, planning and considering it is probably the most important part. Otherwise, it can be very expensive. So what is long-term care and what is the product kind of built to do? So I won't read that full definition, but at the end of the day, there are a lot of different ways and facilities that can be offered through, right? Can be home, can be in an assisted living facility. At the end of the day, it's the custodial care part, right? So there's a trigger, which you see on the right there. It's a resource pool that's utilized when triggered, and it's triggered when an activity for daily living can't be met, when multiple activities for daily living can't be met. And that will tend to be the trigger for a policy, okay? And what that essentially is you pay your premiums for a period of time. That builds a resource pool that you then can use once that's triggered to pay for your care, right? I saw some of the numbers before. I know it's daunting. Earlier in the day, I saw some of the numbers. So that monthly stay can be very expensive. So these policies can help pay that. So they are designed to help with that, with a specific need. They are very custom, so they're built for the individual, and that's why you want to talk to an agent about it if you're interested in doing this. You also want to make sure, of course, budget's an important part of it as well, but it pays for giving care under a variety of chronic health conditions, and again, the trigger would be the ADLs, and not being able to accomplish 2 or 3 of those. It kind of depends on the policy and the state. But they are very customizable. There's lots, and I'll show that on the next couple slides. But I would suggest that there are 3 ways that long-term care tends to be paid. Private always comes in at some level because there's usually a window up front that you'll do private pay, and then long-term care can kick in if you have it. And then Medicaid also covers a lot of long-term care in the country. And there was, again, can't stress enough, there were some very detail-specific discussions in that last meeting that covered how to apply, how Medicare spend-down windows work. So from a consideration standpoint, on the right, you've got your long-term care insurance policy characteristics. Premiums are going to vary. This isn't a supplement plan where everybody's paying the same rate. They're going to vary based on how you change it or how you modify it. So premiums are generally going to vary person to person. They're not guaranteed issues, so there are generally health questions, and they do allow a lot of variation and customization. So considerations are going to be your budget, your health history, your family health history, what your fears are, what your concerns are for the long term, what your expectations are for care, where you want to get care. I think those are all things that when I sit down with somebody else, we'll talk through. The estate, and again, so a lot of that was covered in the last session as well, but your plan for your family, right? Those are all pieces to this as well. So some of those variables and some of the definitions within long-term care, the reason why private pay comes in is that first point, deductible and elimination periods. So that's an insurance term I don't expect folks to know, but when you have a triggered event, that elimination period is going to be the period of your private paying before your policy kicks in. So that might be 90 days, might be 100 days, but you have a period where you're going to private pay until you get to that elimination period. And that feels a lot more like it feels like a deductible as well. And then your benefit period is the amount that you want to purchase. So the length of time. That could be 10 years, that could be 1 year, that could be 3 years. So those are all kind of variables that you have to consider. And so what I will say about long-term care insurance is it's not, folks often think they'll pay a premium and it'll just cover everything no matter where they are for forever. And they're not really built to do that. It's built to give you a resource pool that you still have to make some decisions with. And it's usually for a period of time. Okay, it's not infinite. So that's, you'll pick that period when you sign up for a plan or when you do a plan. So beyond Medicare, lots of questions come up, especially because not everything is covered under Medicare, right? So a few questions that come up, and I'll give you a couple other examples of ways that I work with folks, or questions that come up that are maybe beyond traditional Medicare questions. So I'm sure people in the room have dealt with this. It's the most common complaint to Medicare. Medicare doesn't cover dental, what are my options, right? If you have a Part C plan, there's coverage that's offered a couple different ways in most of those plans. But if you have just original A and B, that doesn't cover dental cleanings and vision or hearing. You have a Medicare Advantage plan, but you have anxiety over inpatient stays, right? So if you've seen a Medicare Advantage plan, one of the higher copays is going to traditionally be the inpatient stay. Usually it'll be a couple days, and you'll pay a rate for a couple days, and then it gets covered. But that's a higher rate than people are usually used to paying. So that's a fear that people will have. Is if that happens, I know it's lower than what it would be if I didn't have this plan, but what does it look like? That's a common fear. I'd like to provide some financial protection for my family. This comes up a lot. Comes up a lot with final expense planning. And I'm retiring, but I'm afraid I'm going to run out of money. Get that one a lot as well. If I go to the hospital, I want to recover in the comfort of my home. And I want the resources to do that. I want to be able to, I don't know how much custodial care I'll need. I want help just with an aid that I know is going to be above and beyond Medicare. If I need long-term care, at some point, how do I pay for it? Right, so all very common. So I have them all here. I'd like to provide some financial protection for my family. Life insurance, right? Believe it or not, life insurance comes up a lot. And it comes up a lot on the final expense side, right? People don't want to leave a debt. They don't want their children to pay for it. I'm retiring, I'm afraid I'm gonna run out of money. An annuity, right? Annuities are an option that people could have for that. Dental care, there is dental insurance. And dental insurance can vary quite a bit. But in the end, a lot of folks want to have cleanings. And so dental care, if anybody's ever had to use it, once you go to the dentist and you have a need, it gets very expensive very quick. So dental care can be dental insurance can actually be a very helpful thing. I worry about how I'm going to pay for assisted living. We talked about that one, long-term care insurance. Medicare Advantage plan, anxiety about inpatient hospital stays. There are indemnity plans for hospital stays. So the ways those are designed are if folks have a Part C plan and they know what that fixed amount's going to look like for that plan, they can actually purchase, really for a pretty reasonable premium, a plan that pays that. So kind of like a long-term care policy, when the event happens, it triggers it, and they get indemnified, they get cash payments. The idea there is it's going to help them pay for other care that they might need. And then kind of the same thing with recovering in your home. That was the last one. There's short-term home care that works the same way. So if an event triggers it, there's an indemnified payment or a payment that comes to that person, and that helps cover those costs, okay? So it gives them some insurance about some assurance about what their costs will look like and how they'll do it. So with that, I will, I don't know if we're taking questions now or if we're going to do a panel, but. Okay.
Okay. Once you become 65, do you have to reapply for your Medicare, or does that automatically roll over? Are you in that 3-month lock-in period, or?
Yeah, you do have the option once you turn 65. It does open up a window, right? So you actually become eligible under age. So you have the option then to get a supplement plan. You don't need to reapply, but it does offer you that opportunity. Yes, it was about whether there's a lifetime limit to what you can spend. So if it's medically necessary, there's a way to have it covered under Medicare.
Can
Yes.
you speak to the wisdom of prior to turning 65 and someone's on Medicare, we were never able to get a supplemental policy, so we were forever paying exorbitant fees. What's the wisdom behind that? Why do they not allow purchasing
Supplementals.
some kind of supplemental insurance?
Yeah, and that's actually a state to state. In this state, there are no supplement plans for folks under 65. It's a risk pooling. What I will say is when you do turn 65, you have that option to get one. People don't realize that, but you do have the option to qualify then. So that's an important piece. I agree with you. It would be nice if you had that. I think it's a risk pool piece, right? I mean, and all insurance is kind of built on that same principle. You pool risk together, and that's how everything kind of gets covered. If it was for folks that are under 65, they're on Medicare, it's going to be a high expense typically. So I think that's what the states. It just wouldn't be viable. Let me put it that way. It's a good question. It's an excellent question. And so the issue that he's referring to, which actually got done literally at the last hour, like the last 4 hours. If you're in a Part C plan, you have a network. So you have a network of doctors that you have to work with. There was recently Anthem and Christ Hospital Network couldn't come to terms on the payments. So in that case, they were going to fall off as of today. And to answer your question, there's not actually a reason. You can't just go in because of that. That being said, the timing's built around the initial window or the open enrollment window. So open enrollment's from January 1st to March 31st. And so I did have a few folks kind of move out for that because they were nervous. And in those cases, you can use that open enrollment window. So if anybody who's in an MAP, that's part of why that's there. If someone's in a Part C plan and that network changes, or they saw a commercial on TV and they bought it based on the commercial, and they didn't kind of look at whether it made sense for them, and they find out, hey, a drug's not on this plan, my network isn't what I thought it would be, or my doctor's not a network. There's a way for them to make that change right now. And so yesterday would have been the last day to do that. So a lot of the timing was built around that, I'm sure. But it's a good point. It almost feels like if that happens and it's so late, that would open up a window, but it does not.
Patients with Parkinson's disease who have not purchased a long-term care plan. I mean, it just kind of, the diagnosis happened. Is it too late for them to buy an affordable long-term care plan?
Tends to be, just because, again, you'll go through underwriting. So since you do go through underwriting, it will tend to increase the premium. But again, what I would suggest is look at the resources in your community, because you don't always have to qualify for Medicaid to get certain help. So use those resources, just use the state programs and see if there's a way that you can get help. So I would encourage that. But from a policy standpoint, again, since there is underwriting, if you've already kind of qualified, that would generally have a higher premium or disqualify you. Again, if I can leave you with any words of wisdom, it would be leverage the resources, not just that are here today, but just become aware of what's available in your community and work with folks to kind of build your advocacy network. That is so important in healthcare. This is not easy stuff to understand. It's not stuff you have to kind of use every day. So use the experts and find people that you trust to advocate for you. Okay? Thank you. Oh.